Hi, everyone. My name is Lois Nganga. I work at Partners in Health Rwanda, and I'm excited to welcome you all to our satellite session today. I would like to take this opportunity to introduce our session chair, who is Nadine Karema, and Nadine Karema will guide us through the rest of the session. Nadine Karema is the Chief Informatics Officer at Partners in Health Rwanda. She has vast experience working at Partners in Health Rwanda at different capacities, including overseeing the implementation, usage, and expansion of electronic medical records for Partners in Health Rwanda and the Rwanda Ministry of Health. She has played a leading role towards building synergy of health information systems and monitoring and evaluation. She represents Partners in Health Rwanda at the Ministry of Health, eHealth Technical Working Group, providing technical support, review, and advice to the Ministry of Health regarding national decision and vision of the eHealth application. Nadine has a background in information systems and technologies, and also in international business and organization leadership. She has vast experience working both in high income and low income countries. So join me as we welcome Nadine Karema to give us a brief introduction of the session and also guide us throughout the session. Over to you, Nadine.
Thank you, Lois, and welcome everyone. I'll be talking a bit about our internal evaluation work group sessions, and the presenters that you will see today will give you some examples of all the work that has been going on through data-driven reflections and storytelling for internal evaluation. So the internal evaluation work group, for which we'll be presenting stories, came about because programmatically we had a lack of timely, actionable evaluations that we could use to inform some of our interventions at Partners in Health Rwanda. And in terms of knowledge management, we did not have enough internal capacity for conducting evaluations. We used to have people coming from abroad, coming in as external evaluators whenever a grant allowed, so that they could help inform our interventions. And more even importantly, we did not have adequate documentation processes in terms of knowledge management. And then on the fundraising and partnership side, our donors, our founders kept asking us important questions like, how can you demonstrate the impact of the work? How can you show the ROI or returns on investment about the intervention that you're making? How can the work that Partners in Health does in terms of health system strengthening in Rwanda be made sustainable and scaled up as the Rwandan government likes to have interventions done? And how does the work that Partners in Health Rwanda do that's different from what its peers are doing? So our approach then, in terms of the internal evaluation work group, we have a platform where we could share expertise across the PH Rwanda programs or groups that work here, leveraging research skills across our existing research and monitoring and evaluation teams, strengthening capacity to design and implement timely internal evaluations, so to inform our interventions, and then using some of the data that we already had existing to document and use storytelling so that the other programs, the other colleagues understand our impact, and it's also easier and more relatable when we disseminate the information to our partners and the community of patients that we serve. And lastly, we set up a long-term culture of programs conducting formative outcome and impact evaluations internally so that they could know whether they're on the right track towards achieving their goals and helping the Ministry of Health in Rwanda in terms of health system strengthening. So basically, it's been a feedback loop of internal evaluations and stories with impact or storytelling of the results, the data-driven reflections on whether our work should continue, expand, and how it can be handed over to the Ministry of Health following our model of Partners in Health of piloting interventions and then handing them over to the Ministry of Health in Rwanda for scalability and long-term sustainability. And on the internal evaluations side, we kept just demonstrating results and providing data-driven recommendations so that the leadership at Partners in Health and all the programs know what interventions should be continued, expanded, and adapted. So I'll be introducing some of our presenters now who will share with you sample projects that came about working with the internal evaluation group. Our first presenter is Jean d'Amour Ndahimana. Dr. Jean d'Amour Ndahimana is the Director of Infectious Disease at IMB, or Inshuti Mubuzima, which is the local name for Partners in Health Rwanda. He's a medical doctor and infectious disease epidemiologist. He's been practicing medicine in developing countries since 2006. He's experienced in designing, implementing, and monitoring infectious disease projects in low-resource settings, and he has led optimized use of resources and tailored innovations to manage infectious disease in these settings. Dr. Ndahimana understands the health system dynamics in developing countries and a particular focus on rural populations. The Dr. Jean d'Amour Ndahimana presentation will focus on the impact of implementing malaria control strategies within schools in a rural district in Rwanda. I'll hand over to Dr. Jean d'Amour so that he could present his work done through the internal evaluation work group. Jean d'Amour, over to you.
Thank you, Nadine, and hi to everyone. I'm happy to share with you the presentation. As Nadine was saying, it's a story, a successful story, which have been evaluated by the internal evaluation team. And the success story is about the school health program, but using school health to control malaria in our settings, which are rural settings, which are the most area of working for Partners in Health. Quickly, without taking much time, our country, as other African countries, the population of the country is a younger population. As you know, Rwanda is an African country, and the population is younger, where the 6%, like 60% of the population has the population who is less than 25 years. And as you can see on this pyramid, the population who is under 25 or who is under even 5 years, 14 years is much bigger than other population. Yeah, what was like an opportunity for malaria, it was at school. It is because 31% of the population, they are at school, and malaria prevalence of the children who are at school, 5 to 14 years, were higher in this population than other population, even higher than pregnant women and under 5 children, which was the knowledge we had until 2017, where the malaria indicators survey showed that now the most at risk group is no longer pregnant women or under 5 children. It is the children who are at school age 5 to 14. And this is a population which is almost forgotten by different program, because many health or different health program, they are targeting under 5 children and they got 15 to 14 years. Even the data concerning 5 to 14 years, you will not find, because many of the countries where they are conducting like what they call DHS demographic health survey, this category of population is not captured. As partners in health is like have the goal or the target or the objective of having like equity and universal health coverage. We found that those children, they are almost 5 days out of 7 they are at school, and it was an opportunity to get and to provide the service at school. And where we were working, where we have like a headquarter, malaria was counting more than 46% of clinical consultation. This is as long as the burden of disease is concerned, the malaria was the first cause of consultation, morbidity, and mortality. This is obvious. As you can see on this graph, where in rural settings, the red line was showing the countrywide, but comparing of the district where partners in health was working, until 2017, the malaria incidence was like this, and it was like 3 times higher than the countrywide. And this is the reason why we were focusing on this issue or on this health condition, which is counting more than 50% of burden of disease there as concerning the morbidity and the mortality. It was the first cause of hospitalization, and it was the first cause of morbidity, and the incidence as it is showing that it was very high. Therefore, the school health was the idea of like serving that category of population which almost have been forgotten. And as you know, the school clinics, they are not a common things in our resource-limited countries. They are there in developed country, but in resource-limited countries, the school clinics, they are not there. The health facility in Rwanda, like elsewhere in Africa or other developing country, they are not closer to the home, like in our country where we are improving. We have like a 40 minutes of walking distance from home to health facility. This is an average. And most of the students, they are in a rural area where the health facilities, they tend to be far from home compared to the town. And the parents, most of the time they go, they work early morning and they go to their routine activity or income generating activities without knowing how the health status of the children is. And the children, most of the time or some of the time, they go at school even though they have like a fever or they have other health conditions they developed or which have been neglected by the parents at some time. And the question here was, what should the teacher do in front of students with high-grade fever? This was the key question. The answer on that question is different. Some can think that if the teacher is in front of such case, he should or she should send back the children at home. But this is what is happening usually. But when the child arrives at home, he doesn't find the parent because the parent went already on their routine activities, farming and other income generating activity. This is causing the delay in health seeking, and which can complicate any disease like the fever, which is very acute and which is an emergency. Therefore, the school health has the objective of educating the students and teachers about the malaria prevention and prevent severe cases due to malaria, due to health seeking behavior or delay in health seeking, and develop the health attitude among the students and teachers, ensure the health environment for the children at the school. How did we do this? The strategy we used, it was like creating the teachers' health club at school. Each school have like a health club of teachers, and purposely we choose 15 schools, whereas the Nadine said, the partners in health is there to pilot a program and a project and showing that is feasible at minimum cost, as we are in a resource limited country, and the program is handed to the government. And the teachers, the total number of teachers in June 2020 was 513, but when we started the program, there was 530. And the schedule of working in a clinic, we integrated this clinic program done by teachers into their routine activity of teaching. And we make sure that this is not interrupting their first objective of educating or teaching the students, because the teacher who was off, he was the one who is in a clinic at school. The second strategy we use, it was integration of school health program into the existing health system, not creating the parallel system, but we make sure that the health center where the school is located was the one who is in charge of supervising supply chain and others. And what Partners did, Partners in Health, is just to catalyze the idea. And the other strategy was to match the fund which have been saved by the teachers within this health club. And we match the fund for just motivating the teacher to continue to work on this work. But those money was used to for small credit among the teachers. And the other strategy was community involvement, where the teachers, students, and parents at the same time were involved, as we are going to show you. The implementation, this is like the picture is showing the implementation where we involve the Minister of Health. The person is the Minister of Health representative giving remarks, and at launching, the students were dancing, as you are seeing there. They started to be involved there because they are dancing, and the songs they are using, they are songs which have the message of preventing malaria. The next picture is showing the teachers receiving the kit, like the minimum kit, where they have a thermometer and the other basic material they can use for screening malaria. We're using a thermometer, registers, and there was rapid tests and other kit which they should use to screen and diagnose malaria, as well as the treatment. The implementation, the integration, as I said, and those are strategies which have been used. As I told you, the matching was, we planned the matching that will not be like a continuous activity, because it was money saved, and they were using for saving and credit. They were gaining even the small interests, which was given back by the one who was a beneficiary of a small credit, and this money was boosting their cooperatives. And 15 schools, as I told you, purposely have been selected, one school per health center, that to make sure that the integration is not overloading the health center. And we trained the teachers, and as you are seeing, 500 teachers. It was an average of 35 teachers per school. And first of all, we appointed the community health workers who are in charge of treating, diagnosing, and treating malaria at village level. And the community health worker who was there in the village was the one who have been assigned to be at school and training the teachers on the practical session. The theoretical session have been done by the health center staff, but for the practical has been done by the community health workers. And we installed also the MNE system using the tablet for consultation, and the reporting was easy. This picture is showing the community health workers is training the teacher whenever the teacher screen the kid for fever and find the fever, the kid is positive or the student is positive for fever. He brought the kid to the community health workers, and the community health workers was showing the teacher how he can screen malaria at the same time when he's treating the kid. And the first dose of treatment when the kid was diagnosed malaria positive was taken at school, and the subsequent doses was given to the student with the message indicating how he will continue his treatment. The outcome, they are looking like this after 1 year. The registered students and teachers, there were about 29,000. It's almost 1,800 children per school. They were registered at school, and among them, the fever cases were higher than even registered because some of the students developed 2 or 3 episodes of fever. Good enough, all those fever cases have been screened for malaria, and 54% of them have been confirmed using rapid test malaria positive and have been treated at school, which prevented those children, like 16,000 cases have been treated for malaria at school, and this prevented like the development of complicated malaria. The other outcome, which have been like indirect to health, but as we are in global health, is school missing. As children were developing the fever and becoming severe sick with malaria, as you see, it was 54 of the all fever cases. The school missing were also increasing. When we introduced the program, after only 5 months, the school missing reduced like by 30% when you compare before and after introducing school health. This is before introducing school health, and here we have line of the reds, like a red line or brown line was the after. You find that the school reduced. We cannot 100% attribute this to the school health, but we are comparing and showing that there is a contribution of school health to this reduction. Even the teachers and directors told us, please don't know what you did, but you come for treating the children, but you regulate the problem of quality of education. The other important outcome was kind of involvement of students in the program. We initiated like a kind of competition for delivering the message, and students were competing on delivering the message on malaria prevention and other health components which have been integrated so far. And you can see here, the students tried to draw this drawing is for a student in primary school who was trying to show the message on preventing malaria, putting the mosquito net, using bed nets, and the seeking healthcare behavior and other components he was trying to show using his own chatting, as you can see here. This was very important on the community because those children were also using the message at the community level, was telling their parents to come in their competition and to show their parents what they did, and they were using the songs, the arts, football for delivering the message which was changing the community. Other benefits, as have been reported by the parents, is the parents who continue their routine income generating activity, using the time they should use to bring the kids or the student at school, and they were using this time for income generating activities. And saving cooperative among the teachers was also another important outcome, because the teacher told us that this kind of cooperative at school helped them to be closer each other. And this was a very important as motivation for the teachers whose their income is not usually good enough. The program sustainability also is like another benefit, because we found that the cost, and even though I didn't present the cost and the sustainability is possible through those cooperatives which are growing now. And we upgraded from malaria and included under health component like adolescent sexual reproductive health and the nutrition component. However, there is some challenges, like a program is still on a small scale and it requires advocacy and resource mobilization, but to show the government of Rwanda this is a feasible project, it can give like a wonderful outcome, both on health, education, and community at the same time. And the other challenge was like the number of fever cases which were malaria negative. Those students were advised to go to a health facility, but at the end, the teacher found that those children, they are not going to the school. And we are looking how we can integrate it, at least the fever management at school, which is being done by the community health workers in Rwanda, and they are doing a wonderful job as have been published. And we are expecting that the teacher can do better, like a fever management, which is not complicated, if the community health workers who is at least knowing reading and writing, those are criteria of being community health workers in Rwanda. If he is doing well, the teacher can do better than the community health workers. Yeah, those are the challenge, but they are, I am proposing the solution, and this is like the end of my presentation, and I thank you very much for your kind attention. Over to you, Nadine. Thank you.
Thank you, Jean d'Amour. Thank you so much for the great presentation, showing us through data-driven reflection how we can provide easier access to care through social justice, and how we can also share the results with the Ministry of Health for scalability of this project. Our next presentation is from Lucky Eugene Shema, and Shema will share with us another example of a story, a data-driven reflection from the internal evaluation work group related to biomedical engineering. Before Shema presents, I would like to give you a brief bio of him. Lucky Shema is the biomedical engineering specialist at IMB. He provides technical expertise such as installation, adjustment, maintenance, replacement, and proper use of biomedical equipment in the rural settings where we work. He has over 8 years of experience in the field of biomedical technology and medical infrastructure, and he has worked both with the government and non-governmental institutions. Shema has a bachelor's degree in electronics and telecommunication engineering with an advanced diploma in biomedical equipment technology. Shema's presentation will focus on biomedical equipment in the 3 rural district hospitals of Rwanda where we work. Shema, over to you.
Thank you, Nadine, and thank you, everyone. I'm called Shema. I'm a biomedical engineering specialist. I'm going to present to you a true story about a biomedical engineering field in a 3 rural hospital working with partners in health. In sub-Saharan Africa, it is common for health facility to receive medical equipment as a donation. It is also common for those donations to come along without follow-up, without spare parts, without access to a local vendor identified who can give a technical support like installation, maintenance, and the other requirements for lifespan of equipment. Over 40% of medical equipment is out of service in the developing world, while only 1% of medical equipment is out of service in developed world. One example is Kankwas, is one location in Gwinkwavu Hospital. In past years, as soon as the medical equipment became defective, they were taken to a small room that serves as a store room for defective equipment in Gwinkwavu. Then hospital staff would go to PH warehouse to request costly replacements that were not always necessary for those equipment. There are three prolonged problems that cause the blocking of medical equipment. One is procurement process. The second one is end user not able to maintain equipment. The last one is improper infrastructure. As stated by the first one, readiness of the facility was not considered before purchasing or receiving donated expensive equipment. We did not consider civil works, electrical, and water supply requirement in order for the equipment to function properly before starting the procurement process. One example, in 2014, Chirehe received a new X-ray machine at cost of over 160,000 US dollars. To this day, the X-ray is only partially installed and not used due to additional work that is required. In order for it to function, Chirehe District Hospital need a power distribution board, a functional dark room, and a developer installed. The second problem is end user not able to maintain equipment. As you have seen on this picture, this is an incubator where nurses were not able to maintain them. That causes the broken equipment. The second picture is anesthesia machine where anesthetic technicians were not able to do daily maintenance. The third picture is delivery beds and suction machine in the delivery room where midwives were not able to adjust and maintain and doing daily maintenance. The last one is digital X-ray machine where radiologists were not able to save and delete unwanted picture so that the computer were full and caused the lack of better functioning of X-ray. The third problem is improper infrastructure. One example is oxygen plant in Gwinkwavu District Hospital was not functioning for a year. This meant that nurses had to cut in oxygen cylinders through the wards. This is very dangerous. If a valve breaks, the cylinder has the power to injure people, destroy equipment, and even breaks through the walls. There are interventions that have made. One was improve procurement process, train end user, mentor clinician and biomedical technician in equipment use, and maintenance, preventive maintenance, corrective maintenance, and routine maintenance of medical equipment. There reviews all equipment purchased request before other steps. There is also training end users in use and maintenance of new equipment and mentorship on a different unit in use and maintenance of existing equipment. The result made on the problem stated before, where the oxygen plant of Gwinkwavu Hospital was repaired and become in full operation. That helps easy access of oxygen and health care delivery become better. Also, the Gwinkwavu Hospital saves the money they use to spend for purchasing oxygen and also save the money for logistics for transporting those oxygen to Gwinkwavu Hospital. Other result as the incubator that was repaired and returned in full operation. This was assured the thermoregulation of neonates and avoid hypothermia disease. It maintains also a stable body temperature that is essential to ensure optimal growth of neonates. The other result, X-ray machine of Greenhouse Hospital was not functioning, but after it was repaired and returned in full operation, that become and better healthcare delivery has become also good to the patients. Another result is the training of clinicians, where nurses, midwives, and biomedical technicians at Greenhouse Hospital have been trained on proper use and user maintenance for neonatology equipment. As you have seen on this picture, nurses and the midwife was trained on how we can clean and avoid other causes of blocking of this incubator. The other result was the training of nurses and midwife and biomedical technician at Utalo Hospital for proper use and user maintenance for maternity unit equipment. This picture shows how ultrasound machine can be maintained in order to keep it in fully operation and saved for good and better healthcare delivery. Another result is related to the procurement process. As you have seen on this picture, Chirehe Hospital has received equipment donated by partners in health, where installation and the other pre-installation requirement has considered before procurement process. This oxygen plant has been installed on time and as all requirement has considering before. This oxygen plant has a capacity of to produce a 24% of bottle. Each one has 50 liters and 250 bars. We have facing some challenges. No specific budget for maintenance at each district hospital. One biomedical technician that the MOH mandate per hospital is not enough to ensure that $1 billion USD of equipment is well maintained and functional. The biomedical technician also that work at the 3 hospitals need further training as well as the space and the tools to work and test equipment. There are remaining gaps with the end user who require more training and mentorship in equipment use and maintenance. We look forward on the next step. At the national level, biomedical equipment survey is a part of accreditation. Individual needs assessment are done for each hospital according to the accreditation standard, and addition, our advocacy is conducted accordingly. Partners in health want to upgrade or laboratory of partners supported the hospital in 2020. In preparation, we have a list of all requirements in terms of software, equipment, training with cost estimation. PIH compliance with national level sports in 2017, Minister of Health in Rwanda has published a policy regarding donation of medical equipment, where it shows how to decide whether or not accepting donation. Donation needs to respond to an identified need. Equipment must be satisfied and safe, of quality, user-friendly, and has at least 70% lifespan remaining. They are a vendor for spare parts at national level. Installation also should be a part of the donation. Also, there is the other policy published in 2017 regarding the commissioning of medical equipment, where the procedures shows the all steps for removal from the service of medical equipment and after disposal of this medical equipment. Their recommendation: donors should provide all technical support required, including technical documents, installation guidance, accessories, and spare parts. The placement plan should consider also pre-installation works, installation, training for clinicians, and maintenance requirement. I have acknowledged Almighty God, partners in health, and it supported the hospital staff, internal evaluation working group, Wigna Foundation, Ministries of Health in Rwanda, and the government of Rwanda. This is the end of my presentation. Thank you, everyone.
Thank you very much, Shema. Thank you, Shema, for this presentation about biomedical equipment and how we can, through storytelling, how you've shown us how donations can be sustained in the rural settings where we work, and how through our social justice approach of providing care to the poor, we can not only bring access to care, but also use these medical equipment that are needed. Our next presenter is Placid Habinshuti. While Placid is putting up his slides, I'll give you a brief bio about him. Placid Habinshuti is our Senior Health Information Systems Implementation Manager at IMB or PH Rwanda. He's supporting both the clinical and informatics department in the use of electronic medical record systems to improve evidence-based clinical care and inform priority monitoring, evaluation, research, and quality improvement efforts for core program activities. In addition to his work, Placid is a core member of the PH Rwanda Internal Evaluation Work Group, where he provides technical leadership and expertise to evaluation activities for both clinical and non-clinical programs. During this session, Placid will contribute and present his experience and lessons learned while implementing a community-based evaluation in a rural low-resource setting. Placid presentation will focus on the lessons that is learned through the process of conducting a community-based evaluation program in rural Rwanda through a social justice lens. While Placid is presenting, I would like to encourage you to put up your questions on the virtual portal. So far, I'm not seeing any question. Actually, I see one from Mariela, or two. So please feel free, and you're very welcome to put up your questions on the virtual portal. Placid, over to you.
Thank you, Nadine. Hello, everyone. So the program we're going to talk about is ECD. In full words, is the Early Childhood Development Program, which is a program that focuses on improving the well-being and the nutrition status of children under 3 years old. All right. So a brief background on why the ECD program came up. It's mostly related to the high malnutrition rates, mostly stunting rates that was in one of the districts where Partners in Health works from, and the district is called Burera. It had from the DHS conducted in 2015, it had 42% of stunting among children under 5. So for those who don't know, stunting is a form of malnutrition where the children don't grow in height as they should according to their age. So 42% stunting, that was a really high number because the national rate was 38%, still also high. And then we chose to start that program in Burera, but also some evidence from around the world has shown that the more care to the baby, whether nutrition or other care to the children who are in the early years of life, like 3 years and below, has shown that it has a great impact on their nutrition status. So then the ECD program chose to target the children who are below 3 years old, and also the pregnant women and lactating women, so that they can start taking care of those children in the early years of life. So The ECD program intervention, it is an integrated community-based intervention. It has multiple activities that we can talk about here, like growth monitoring, then cooking demonstration where they show the mothers and the caregivers of the children how to cook a balanced meal, provide them with some food supplement, infant and younger child feeding behavior, the wash project, and also taking care of the mothers during the antenatal and postnatal care, vaccination, then family planning to ensure the mothers, once they've given birth, how they should go to family planning in order to space their birth, and also social protection. So the location of the program is, as I said, it's the northern province of Rwanda. So you can see on the chart on the right, the sector is called Rugengabari, and is somehow in the south of Burera district. Then the evaluation we are conducting with the ECD program, it's we conducted the baseline right before the beginning of the project. Then currently in 2020, we are doing a midline. Then next year we'll do an evaluation once the project is ended. Then we'll be able to compare our baseline to the evaluation to see the change. And we've also chosen a control group, which is an area, another sector in northern province in Rwanda, but where this intervention is not working from. So we'll be able to compare the change, the difference in the Rugengabari district to another sector that is a control group. Then what we are going to talk about here in this presentation is going to be mainly related to the baseline that we've so far conducted. And the evaluation questions that we had at the baseline was to see like the implementation, is it going according to the objective? Then is the program design really going to meet the needs of the beneficiaries? Then the third question was the interventions that have been set up for the ECD project, are they enough, or is there something that we can adjust along the way we are implementing the program? Then the tools we used, this was a mixed method. We used some quantitative questionnaire. Then for the qualitative, a focus group was conducted with the beneficiaries. Some results we can talk about here. First, on the enrolled children, you can see on the chart on the left, most of the children that were enrolled, the higher proportion were between 12 to 23 months old, followed by the ones who are 24 to 35 months. So the criteria for enrollment was children who are below 36 months. And then on sex, the higher proportion was female with 59%. Then some key indicators on child nutrition and child care. First, the most important indicator here on nutrition is stunting. Among the children enrolled here, the stunting rate was 38%. So if you compare this 38% to other places around the world, this is really too high. And then underweight, which is also another form of malnutrition, where the babies and children don't gain weight as they should, was 17%. On child care, 37% of the children had experienced an inadequate care. Then 32% of the children were left in the house with another child of 10 years or younger. So that means like the mother leaving home to go and work or do other stuff, and without anyone to take care of the baby apart from another child who is 10 years or younger. Also, 7% of those children were left alone, just alone in the house for 1 or more hour in a week. On the qualitative, on a father involvement, on a parental involvement in child care, we can see that father involvement is really, really low. For example, if you look at making a decision on whether the child attends ECD services, only 3% of the time the father took the decision alone, yet 57% was for the mother. So you can see at all charts here, even on the taking decision of what the child eats, most of the decisions are made by the mother, where the father is really not being involved. So one of the interventions that the program got from this was to have the father being involved in the child care and also taking care of their home. From the focus group discussions, we asked the beneficiaries a number of questions, but there are two main questions that were showed what changes can we do to the program at the baseline. So the first one was asking, what are the other activities do you think should be integrated into the ECD centers? So we're like knowing, apart from what we've designed, what are the other activities that you think? And then the respondents said that there need to be some family empowerment through giving them the inputs. For example, if you're telling the family to cook a balanced meal to their children, sometimes they don't even afford that good food. So we had to give some inputs and also some cooking materials. Those ones were needed and were provided to the families. Another suggestion was to include play activities at the ECD centers for so that when the caregivers, the mothers come for the session, they bring their children, then they can be playing around with the play activities at the center. Another question here that was really important was asking what could make ECD centers successful. Then the beneficiaries, they said there should be an enhanced supervision. Then from here, they meant like, if the mothers go to the ECD centers, then they tell them, this is how you cook a balanced meal. We shouldn't be expecting that they are going to do it. So there should be like enhanced follow-up, like going there, do some home visits, see if they're learning well, and they keep advising. Another one was to involve the stakeholders. We learned from the baseline that, for example, the community leaders, they have a higher impact on this project because if they come to the beneficiaries who were supposed to go to the ECD centers and they tell them that program is really not important, so they were going to leave that straight away. So we learned that local leaders should be informed on what's happening, then involved in all the process of the project. Similarly to all the healthcare providers in the sector, mainly the nurses and the community workers who are the front line on the field. So the lessons that we learned from this baseline evaluation, the first one was like the needs that the beneficiaries needed. So like when we analyzed the responses from the focus group discussion, we saw that from the strategies, activities that the program had planned, there should be some more activities added. For example, the mentorship I talked about, where the beneficiaries said we need to follow up to make sure that we are doing it right on the way we were taught. Then another one was rehabilitating the ECD center. So the government of Rwanda has done a great job on establishing the early childhood development centers throughout the country. But due to lack of follow-up, some of these were not in a good infrastructure shape, and they did not have some equipment. And the program had to do some rehabilitation and equipping those centers. The third was to provide inputs to the beneficiaries. Then the program had also to do some adjustment on the procedure of the parent session, the way it was. The beneficiaries got some recommendation that they had to do some adjustment. The second lesson that we learned was like it was a little bit difficult to find the beneficiaries for doing data collection for baseline. So, for example, data collectors had to go to homes, and when they get there, they find that the father or the mother has gone to find some stuff to do. Then they had to chase them around. But we learned that to interview them when they come to the ECD centers for these visits that they had will be better. So that reduced the cost for traveling. Then the tools that were needed, such as the scales, were borrowed from the health centers, then they were kept to the ECD centers. And also some demonstration materials that were needed during data collection. For example, if you're asking the mother, does your child grab something when you showed it to him? So it was easy because there were some materials on the wall of the centers, so you could show like an image to the mother and ask, does your child do this? Another lesson that we learned was to leverage some already collected data, because normally when you do an impact evaluation, in order to attribute the change to your program, you should have like a comparison group where you can say, I exposed this beneficiary to this intervention, but the other beneficiaries who have similar characteristics who did not get an exposure, you can see there is a difference. But impact evaluation usually use a lot of money, and the project had limited cost. So we learned that there was a project that collected the similar data on another sector that is in Ibrera, not far from the one where the intervention was conducted. Then they were willing to share the data. Then earlier at the baseline, we harmonized the data collection tools, so the questionnaires were the same. Then we were able to get their data easily for comparison. And also they were willing to share some of data code that we used during analysis. Another lesson that we learned earlier when I was talking about the focus group discussion results, I talked about involvement of the local leaders. So we learned that local leaders should be informed. So we informed them on the program, how it was happening. Then as soon as the baseline results were available, the dissemination was done to the local leaders and health facilities. Then when we showed them like those high rates of stunting or malnutrition, everyone was like, really this program is needed, and then they started encouraging the beneficiaries to attend the sessions. So some recommendations that we can give here are, the first one, to any project to do a needs assessment right at the beginning of the project, like in the project design. Go there where you want to do an intervention, go and interview the beneficiaries, know what they really need, because sometimes projects are designed, but when you go on a field, the intervention is not matching with the context, the beneficiaries, you don't have their buy-in, and the program is failing. And the second one was to track the same indicators over time. So if you have the same indicators from baseline to the evaluation, it's easy to do like a comparison. But when the program is not well designed and there are some adjustment to indicators as the project go along, it's not easy to compare something. If an indicator was collected just for the evaluation, you can't compare it to any other thing because it wasn't collected at the baseline. And also there are some standardized tools that are available out there, depending on the field where the project is. For example, this was a malnutrition sector. So there were some tools that are available online, such as we can talk about the Ecd, the OMCI. These are standard measurement tools that you can download, and those tools, they come with some guidance, some analysis code, so it's easy to use those tools, and you don't have to recreate something from scratch. So The last recommendation that we can give here is the flexibility of the project. For example, some donor projects always, sometimes they come with a strict timeline, with a strict intervention. And when you go out there starting to implement the program, you find that there should be some modification to be done. You find that it's not matching with the context. So the programs should be a little bit flexible to adjust with what we are seeing on the field. Lastly, as we are acknowledging those who supported this baseline evaluation, we acknowledge the data collectors who did a great job here. They had to go in the community. So Lujengabari sector is really in rural. We acknowledge their support here. And also the beneficiaries, they were willing to contribute and participate in the baseline. We didn't have anyone saying like, I'm refusing to answer your questions. Then the local community and health facilities, everyone was really helpful. They lent us some tools that we used like scales. We acknowledge their support. And also the Wegener Foundation, that funds the IEWG, we acknowledge their support. That is all for my presentation. Thank you.
Thank you very much, Placid, and thank you to the audience for the questions. We'll start with the questions from the audience. The first question was from Mariella, just to like Eugene, with a focus on donated biomedical equipment. Mariella is asking you, Shema, what are your recommendations on how stakeholders in the medical donation ecosystem can enhance sustainable and efficient use of equipment? Over to you, Shema.
Thank you, Nadine. The stakeholder should be provide donation as a response to the problem that have by beneficiary, not to provide other problems to them. To achieve on this, as I have said, Minister of Health in Rwanda has developed and published a policy regarding donation of medical equipment. In developing country, developing words, I recommend to have a policy that shows all steps to receive a donation of medical equipment. As an example, stakeholders should donate new medical equipment, not the used ones. If they provide the used equipment, it should at least have 70% of remaining lifespan in order to provide and to reflect to the problem that the beneficiaries has. Also, they should involve all beneficiaries from the starting up to the end up of the project by considering the all requirement like pre-installation works, like training of end user, like maintenance requirement and technical document as a reference in the learning of equipment. Also, they should also considering how equipment will be repaired when it will become broken, for telling the end user beneficiaries where they will buy the spare parts. It means that stakeholders should remain in contact and do follow up on the donated equipment so that the equipment will remain in full up to the list of lifespan. Thank you, Nadine, and everyone.
Thank you, Shema. And I think, sorry about that echo. There is a comment related to that from Gina Teddy. Thank you, Gina. So Gina was relating her experience and saying that the presentation on equipment donation is becoming a real problem of imposition, even if it doesn't meet the need of the country. Gina is saying that they had a real problem from another country that was donating equipment to support the hospital at the onset of the COVID, but this was not practical, and the technical expert was literally being threatened to accept. Her comment is that donation must be relevant and sustainable, and it is time for it to be negotiated rather than imposed, where it will not add value, yet the North forces it down to this country. So Shema, I wanted you to address this comment and maybe explain to others what the Ministry of Health or the government of Rwanda has put in place in terms of donated or any equipment that's coming in the country. Over to you, Shema.
As an example, in Rwanda, we have, as I said, we have a donation guidelines and procedure. When stakeholders or donors need to donate equipment in Ministry of Health or other beneficiaries like hospital, it should follow the steps shows in that guidelines, like to involve all beneficiaries at the beginning, and also when stakeholders will not accept to follow the steps shows in the guidelines, will refuse to accept or receive that donation. So as a recommendation or thought about this, it is needed to have a guideline that will help all countries or developing countries to receive equipment that will reflect the problem of beneficiaries, not to become also a problem or not using for healthcare delivering. Thank you, Nadine.
Thank you, Shema. I see we have one question on the virtual portal for Jean Damour, and the question is from Mariella. What strategies were used and are best to keep the community health workers and teachers engaged in a program such as the school health program? And before Jean Damour responds, I would like to remind our audience that you can ask your questions on the virtual portal. Thank you.
Thank you, Nadine. And thank you, Maria, for the question, which is very key and relevant on the program implementation and sustainability of the program. This is very interesting. The strategy which have been used, and we are also strengthening them for the sustainability or continue to engage the teachers or community health workers. First of all, the community health workers, they are there for kind of supervision of the school health program. As long as malaria is concerned, the cell coordinator or the one who is coordinating the community health workers at the village level or cell level, he's the one who is he is in charge of supply chain. And he's the one who is in charge of reporting to health center, because the school is being taken like another village. And whenever we are integrating the school into the existing health system, it is easy for sustainability, and it is easy for engagement of the beneficiaries. The other strategy which is being used is grouping the teachers together. Most of the country, and including our country, whenever we are thinking about the health, to address the health condition at school, we are trying to put the effort, the emphasis on students, while the teacher at school, he's like a parent at home. When you want to implement the program in my house or at my home, it's better to come closer to the parent before you go to the children. This is or combining both instead of taking on the children. I am saying this because there are many health clubs at school, but the turnover of students is very high because after 6 years, every student who was in the club is out, and you should recruit others. But for the teachers, the turnover is not too high like the student. Grouping the teachers together, it's the best strategy. They are grouped for sure because they are at school. This is the first step of grouping them. But when we create the club, a health club for teachers, over 35 teachers, which is an average of teachers at school, and they are having like a meeting, even the weekend they are coming because they are having now the saving and credit group. They are gaining like a kind of incentive or benefit, even though it is there, they can take like a credit, but it is easier for them, and it's a kind of motivation, and is taking the credit and is bringing back the interest, which will boost the group, the money for this group. And they are at the end of the year or 2 years, they are sharing the interest they gather together. This is a kind of motivation for them. The strategy of grouping them is another one, and the other one is not overloading them. Whenever you are overloading either community workers or teachers, it will not work for a long time. It is not sustainable. But when you are taking a school and you are making like another village in the same village, you are reducing the work of the community workers who are working free of charge. They are volunteers. And the teachers, they are reducing the work of the community workers. But when they are treating also the student at school, they are not overloaded because the cost of revising or repeating the lessons which have been given while like 20 students were absent, the effort is higher than like a screening. When you are off of your teaching, you have an hour off. It is very easier to go to the clinic for this 1 hour than repeating lessons provided or given while 20 students were off or missed because they were sick. Even though on one, at first glance, we can say, no, the teacher, they are trained to teach, not to treat. That's fine. And you are overloading them. But the huge work will be on repeating the lessons or the lesson to those children who missed their school because they were sick. And there were many. When you are comparing like 16, at least one child missed school in a year by default, dividing the registered by the fever cases. Yeah, this is another strategy. The last one, it's a kind of involvement of beneficiaries. The teachers, they are beneficiaries of this program as community workers they are. If the teacher developed a fever, his colleague is testing him, and him also is not wasting the time of going to a facility. If he has malaria, he is automatically treated. And the probability of having malaria, as you see, it was more than half. And the time lost by teacher when he was going at your facility and the time lost by the student, combining such kind of time, their involvement and their commitment, their engagement is increased by having this program because it is helping them, it is helping the beneficiaries and those who are actors of this program or those who are leading this program. Those are strategies, grouping them, not overloading them, but like in community involvement or their beneficiaries involvement. Those are some of the strategies which are being used for continue or making sure that the program is sustainable. Thank you very much. Unless there is another question, I can say over to Nadine. Thank you.
Thank you, Jean d'Amour. We have one more question on the portal, but before that, I take that one. I will let Zainab, who has been raising their hand for quite some time, talk. Zainab, over to you. Zainab, you're still muted. Unless your question has been answered, please go ahead and unmute yourself and speak. All right, we could not hear Zainab. So we'll take the question that's on the portal. The question is addressed to Placid from Peter. Thank you, Peter. The question is, what strategies can you recommend for evaluators to enhance local buy-in into evaluations? Because Peter says that they've had previous experiences where local stakeholders have been skeptical of participating in evaluation process, mainly because they sometimes fail to see how the whole process benefits them. Over to you, Placid.
Yeah, thank you for the question. So there are a number of recommendations that I can give, but the first one was in the PowerPoint, and it's about needs assessment. So if you want to conduct an evaluation on a population, so they first need to see that the evaluation is needed. For example, if some baseline were conducted, or if you see the need over there, you can just go to them and tell them, so in your area, we see that there is a burden of this problem, which is not in other places. So if you want to do this evaluation here, you are going to benefit on an improvement, and this burden is going to reduce. So you try to show them like the burden they have compared to other places, and you show them that your evaluation is going to lead to an improvement that is going to take them to the other places. Another thing is like show them the benefit that is there. So those once you have those results, come back to them and tell them, you see, these are the results of the evaluation, and we are going to take the results to the decision makers, and we are hoping that we are going to get a response. Then also, if you ensure them we are going to take the results to the decision makers, there should be a consistent follow-up to the decision makers, because sometimes you, for example, in our context, if we go there and show the high stunting rate in a sector, and then we take it to the decision makers and they don't address it, we should keep following up to ensure that what we promised to those people is getting addressed. And also another thing is the methodology that you are going to use in the evaluation. So sometimes what some evaluation have as a challenge is overburdening those who are participating. So for example, we want to conduct our interviews on Wednesday. Then the beneficiaries, we take them the whole morning, like we start at 8 and then we finish at noon. So that is not practical. So you should ensure that you take them the little time possible, then on their convenient hours. So in the case of what we did for ECD, we were interviewing them when they've come to the centers. But whenever we needed to do like a follow-up on something that was misunderstood, something that was not captured well, we were calling the beneficiaries saying, what is a convenient time for you? When do you think you'll be available? So if it's in the evening, we had to go there and ask them in the evening, not telling them like, we want to conduct this evaluation between 9 to 10, then they have to leave their work to come and answer your questions. So when you do that, they don't get a buy-in. So then another thing is also to involve the influencers in that place. So in the case, I don't know the context you're talking about, but in the low and middle income countries, most of the time you see when you're in the rural, like the local leaders, the church leaders, those people are influencers. So when you want to conduct an evaluation, they should also be aware so that while you are doing your evaluation, they don't pass around another message saying that what is being done there is wrong. So they should be aware and also get your buy-in from your beneficiaries by showing them the benefits they are going to get from there. So the benefit shouldn't be like monetary benefit, because when you go there and say, if you participate, we are giving you this money, that is somehow wrong. They may participate because of the money, but give you wrong answers. But show them the improvement that they are going to benefit as a whole when they participate from that evaluation, and give honest feedback and what you are going to do with that feedback that is going to benefit on them. Thank you.
Thank you, Placid. So I did not see any other questions, but as you were all speaking, I started wondering, given that there are questions about how this can be contextualized in other settings. My question to the three of you, starting with Jean d'Amour, is what existing skills and structures do you need for other groups to have this type of local internal evaluation work groups or local internal evaluations?
Thank you, Nadine, for this question. I think wherever they want to initiate or to start the internal evaluation, it's good first of all to know that the advantage of having this internal evaluation. One of the advantage of having the internal evaluation is that the internal evaluation is less expensive compared to external evaluation. This is obvious whenever you are hiring like a consultant, either is individual or company to come and evaluate your project. Sometimes is expensive compared to use the local staff and evaluate your project. This is the one. The other one, which is an advantage, is the internal evaluation. Whenever it is being done by the staff who are in institution, the recommendation and the findings will be used, which will shift from having like a document with good recommendation, good finding, to action. We have knowledge, but for most of the consultants which are being done in our country like elsewhere is that we hire the consultant and he does a good job and he releases the report. There is a dissemination. And after dissemination, because the one who knows everything in the report, he's the consultant. He goes back to his country or to another consultant, and no one will have this knowledge for shifting from knowledge to the action. And some of the report of the consultancy report, they are kept into Kabet and they are remaining there without an action. But whenever you are having an internal evaluation, the findings, they are more inspiring the program managers because you are together, you are having different meetings with them and you are presenting the findings and everyone can discuss those findings because they are on your settings, they are in your organization. However, they will know also, they have to be like, they have to respect like the scientific honesty, not manipulating the data because they want to show that your project have a successful story or a successful impact. At the point you can manipulate the data, this is like a consequence or like a kind of bias which can be introduced by internal evaluation, but it can be mitigated. It is not huge unless the people, they don't want to mitigate, but this bias can be prevented as long as you want to achieve the impact or the outcome which are real, not fictive one. Those are the advantage and like a kind of the consequence of the internal evaluation. And I think whoever we want to implement this have to take into account those advantage and disadvantage for sure. Thank you. Over to others.
Thank you, Jean d'Amour. What about you, Placid, as someone who has led evaluations? What skills and structure should the other people who wants to replicate this model have?
Thank you, Nadine. So talking about the skills that people who want to come up with evaluation should have. First, before talking about the skills, I would say it requires the willing to learn. So in case of the internal evaluation working group that we have here, as when it started, none of the members was considered like a good person, like an expert in conducting impact evaluation. But we gathered everyone around who had some skills of research and monitoring and evaluation, who was willing to learn and share the knowledge. Then we did kind of our assessment, like between us, what do I have? Do I know to conduct some qualitative analysis? And the other one, does that person know how to do some analysis using this type of software? So we gathered as many people as we could who had at least some knowledge on research and monitoring and evaluation. Then between us, we helped each other, and then our desire to learn, we were leveraging the skills from external visitors who come to the organization for some few months. If they are good in something, they come and spend some time with the group teaching them. Then at some point, we moved all together to another level of knowledge where we were good in impact evaluation. So I would say briefly the skills needed are research, monitoring and evaluation, a little bit of management skills because they have to be someone who is making sure everything is moving around. But those should be minimal skills that most of the people can have. As long as those people are willing to learn and to collaborate between each other, they will achieve it. Thank you.
Thank you, Placid. So leveraging local skills, building local capacity, and as we like to say here, making sure that we own the E of M&E, because most resource-constrained countries only do the monitoring locally, and the evaluation tends to be done by external experts that are sometimes costly. So our next question on the virtual portal is addressed to Jean Damour. It's a question from Peter. Peter is thanking you, Jean Damour, for the great presentation on leveraging schools to control malaria. And he's asking whether you think that the existing structures can also be used to control NCDs such as rheumatic heart disease or other diseases common in low and middle income countries. Over to you, Jean Damour.
Thank you, Nadine, and thank you, Peter, for the question. It is a very important question, and as I said, this program, school health program, it is not even called the malaria program. It is school health program. It can integrate different health conditions which are being left behind because we are missing this opportunity. As Peter said, it's a good opportunity, as I said in my last slide, to integrate like a kind of fever management. He's talking about rheumatic fever, which at the end is the first cause in resource-limited countries, which is the first cause of heart failure for many people, and they have heart surgery which are being done for the children. And at the beginning, it is going without, no one knows, because it's just a kid who is developing the fever, tonsillitis, and he's treated or not. If he's not treated, he's developing the antibodies which will be against him at the end. This is an autoimmune disease, but it is very easy to control a kind of rheumatic heart disease at school, where you are going to screen the fever, screen tonsillitis, because tonsillitis, even at the hospital in our countries, nothing else is being done except to look at the tonsils, and you make sure that there is no tonsillitis. There is no laboratory which is being done. Most in the case, they are just an eye of medical doctor and prescribing antibiotics. This can be done by the teacher at school. And for the poor countries, those kids, they are neglected. And when it passed without noticing this fever, the child at the end or in the future will develop heart failure, and the rheumatic heart disease will occur to the children, while it will be prevented by screening fever and treating the kid at school. Yeah, I totally agree with Peter that we have to integrate other health conditions. As I said, we integrated already the adolescent reproductive health at school. It is very easy because most of with the education for all, most of the pregnant teenager pregnancies, they are coming from the young ladies at school. And this can be controlled at school if you want prevention of this one. And if you want even early diagnosis of those teenager pregnancies, because they tend to hide it, it will be better to do it at school, because it is a huge opportunity to control those kind of health conditions which are not. I will not end my discussion without saying about integrated tropical disease, which can be controlled, and other health issues. It's a good platform where we can control almost the disease in resource-limited settings without injecting a huge money, because even we tried, we were thinking about opening like a clinic and sending nurses at each school, but we find that we will have like nurses which are, we have in our country, we have like 523 health facilities. and you have more than 3,000 schools in the country. If you allocate or you deploy a nurse to each school, you can imagine the number of nurses you will need. But training the teachers, they can at the same time having like 2 or 3, even 10 children to 35 teachers, they will not be a big number. It will not overload them, and it is possible. I think this is a good one. It have to be discussed, and it have to be grasped like an opportunity for everyone who is in limited, in resource limited settings, where having even the community focus is difficult. They can start by having like a school health program and making sure that they are responding to some health issues in their community. Thank you. Over to you, Nadine.
Thank you, Jean d'Amour. Thank you very much. I don't see any more questions, but as Placid was speaking about evaluations, I remember a quote from Mahatma Gandhi that says that whatever you do for me but without me is done against me. So I wanted to, for you to reflect and share your experience on how you've worked with internal evaluators. So I will start with Shema. What has been your experience working with an internal team of evaluators versus being on the other end of working with an external evaluator? And how have you included, made this process inclusive and listened to the voice of the patient?
Thank you, Nadine. My experience, I have seen that the external evaluator can do evaluation and present the findings, but after presenting findings, he left the organization. He cannot help in monitoring or evaluation in order to see if the findings is solved after evaluation. But as internal evaluators, after presenting the findings, also they contribute to see and to train the implementer how they can implement the findings in order to solve the problem step by step, as is always involved with him and or her in order to solve the problem findings in the internal evaluation. Thank you, Nadine.
Thank you, Gemma. And Placid, also as part of your work in the internal evaluation, how do you make sure that the voice of the patient or the beneficiaries is included in the evaluation process?
Yes, thank you, Nadine. So in my experience as working with a program in internal evaluation, what I've seen, sometimes the programs come to us with an idea of how they think the evaluation should be conducted. And sometimes we have to advise them, like, if you ask these questions, it's really not going to tell you what the beneficiaries think. And sometimes we have to go while designing those questions that are going to be used as evaluation. We have to go there in the field and ask the beneficiaries, like, do you think these are the right questions that are going to gather some input here? Then we see what the program wants. Then we also talk to the beneficiaries and then understand their side of view. Then another thing is after the evaluation, during the dissemination, like the format of the dissemination. So earlier, Jean Damour talked about the differences between internal and external evaluation, where he said that external evaluation, sometimes they give us a huge report, and it comes to the organization, sit there without someone to read it through. So, but the difference with the internal evaluation, so far what I've seen in my experience, sometimes we do an evaluation, we send to the program the format where we think is good, and then the head of the program, they look at it and then they're like, I'm not understanding this thing. Can you change the format? And then we go back and change the format to what they are going to understand, what is going to inform them. But when it's an external evaluator, they send you the report, you pay their money, they've disappeared. But with as internal, we keep discussing with the program. If you change the format of this report in this way, this is where I'm going to understand it. This way I'm going to disseminate it back to the beneficiaries and they are going to understand it. So when we disseminate, for most of the time, we have like 3 formats. Then the program leads can choose what they think is going to be more informative.
Thank you, Placid. Yeah, so I think we've come to the end of our session, unless there is an additional question. So thank you very much to our panelists for sharing stories related to our pathway to social justice through data-driven reflections, internal evaluations that help us be more stewards to the donors that are funding our work, to the communities that we serve, to the stakeholders in all the interventions that we undertake here in Rwanda. Thank you again, and have a nice day, and enjoy the rest of the conference. Thank you.
Thank you.